Okay. All right. This is the live version, right?
Yeah.
Okay. Yeah. I was able to get it eventually. Okay. So hopefully others will be able to see us. Um, should we wait a bit, or we can start?
Can you share?
Let me see. It's still using Messenger.
Yes.
Okay. Okay. I think it's already live on my page.
Okay. Let me check.
Okay. So we have people who are joining in. I think we are having views already.
Okay.
Okay, let me start so that we won't keep people waiting. Welcome to the second section of microbiotics BioTalk. And this evening we are having the state epidemiologist of Ekiti State with us, and that's in person of Bosede Alowooye. I think I pronounced that well, ma. So she'll be discussing about how to get prepared for the next epidemic that is likely to happen, and even how to get ourselves prepared for this present epidemic that we are encountering, the pandemic, the COVID-19 pandemic that is presently going on around the world. As we know, we are having a kind of should I call it an insurrection of new variants of COVID. So on this edition of BioTalk, she's going to tell us how to manage this present pandemic that we're experiencing, and the experiences she has had with it, and how to also manage anyone that we're going to experience later in the future. She'll be breaking some words down, and we are hoping that we will have a kind of interactive section where people get to ask us questions, follow us, ask questions, should be able to answer it, and then we'll be able to learn more than a thing or two. So based on that, let me welcome her on board, and she can take over from here from me. Thank you very much. Welcome, ma. You are on. Okay.
I think we are back.
All right, we're back. Yeah. You started one on the.
I've closed it.
Oh, okay. So why are we still back in this room, this Facebook room? All right, all right. Uh, I think we should proceed, right?
Yeah.
So I've done some introductory. I've given some introductory talk,
Okay.
and I've already introduced you. Maybe I should do it all over again. With us here, we are having the state epidemiologist, the chief epidemiologist of Ekiti State, with us, and she'll be giving us a discussion, an enlightening discussion about the present pandemic and how to prepare for the next pandemic that we'll be having, and how she has been with others, how she has been able to manage this present COVID-19 pandemic. We are in the midst of the, how should I call it, the insurrection of, or the resurrection of other variants, and the COVID-19 pandemic is far from over. So she will be giving us information how to be secured earthwise and how to uh, prepare ourselves either personally or in community settings. Uh, and let me just welcome her so that she'll take over from me from here. You're welcome, madam.
All right. Thank you. Thank you very much, Tayo. I hope everybody can hear me. My name is Bosede Alowooye. I know Tayo must have hyped me before I came back online. I am Bosede Alowooye. I'm a mom of 4 beautiful kids, teenagers that whose life mission is to frustrate me and pull my legs. So that's my first vocation. I'm a mom. Then I am the acting state epidemiologist for Ekiti State. I am a microbiologist and also with I hope you can hear me. Am I still on? Am I still on?
Yes, yes, you are. You are. You are.
Thank you. A call tried to come in, so I forgot to put the do not disturb. I have particular interest in emergency preparedness and response and in molecular biology. So I will be sharing my screen. I'll be talking about pandemics. I'll be talking about pandemics in general and also the COVID-19 pandemic. I'm trying to share my screen, but I could find it when we test run yesterday, but okay, I've seen it. Let me share my screen. Can you all see my screen now?
Yes, yes, we can. At least I can
Okay.
see it from here.
All right, thank you. So I'll be talking about health security, getting prepared for the next pandemic. I'm using my phone because I don't Facebook on my laptop, and it will take a while for me to log into Facebook on my laptop. Laptop is strictly for work. So strictly for work. So I'll be talking
This
about,
work too. All
yeah, no,
right.
for my laptop. So I'll be using my phone. So I'll be talking about basic terminologies, trying to understand all the different jargons we use during outbreaks, pandemics, endemics. So let me just talk about endemic. When we say something is endemic, that means it occurs at a predictable rate among a population. Like in Nigeria now, malaria is endemic. We have malaria year round. We can say that, okay, at a particular time, about 60% of our hospital admissions will be for malaria. So it's endemic in Nigeria. In Edo State and some few states, Lassa fever is endemic in Edo State, in Ondo State, in I think Ebonyi State. But when we are talking about outbreaks corresponds to an unpredicted increase in the number of people presenting a health condition or the occurrence of cases in a new area. So for somewhere like Ekiti now, when we have a single case of Lassa fever, we have an outbreak. We have an outbreak already because we do not have Lassa fever. The only case of Lassa fever we have had in this case was, I think, 2017. So a single case will be an outbreak. But for some diseases, you might have like 10 or 15 cases before you will declare that you have an outbreak. For something like cholera cases, you might have like 5 or 10, or measles before you can say, okay, this is an outbreak. When we're now talking that you have an epidemic, that means you have an outbreak that is that spreads to larger geographical area, and that's what we had in 2017, 2018, when you have Lassa fever spreading to other states that we don't have them in the country. So other states, like almost like half of the states in the country experienced Lassa fever outbreak, and it became an epidemic in the country. So a pandemic is an epidemic that now spreads globally, like this current COVID-19 pandemic. So we need to understand, I think because it's a phone I'm using, we need to understand what are public health emergencies. It's an occurrence of illness or health condition that poses a substantial risk. When you are saying you have malaria, you have cases of people having malaria, it's not an emergency for us in Nigeria or in the tropics unless you go to the temperate region. Then malaria case might be an emergency. So they can be an or something that is not even a communicable disease. We have had emergencies where we have poisonings. We have lead poisoning in Zamfara. We have methanol poisoning in some states, and I think Bayelsa states, on those states, we have seen people coming down. So, but when you are talking of public health emergencies of international concern, that means it's an extraordinary event like the COVID-19 pandemic is a PHEIC, is of international concern, and you have to bring in the international health regulations. It constitutes a public health risk to other states through international spread of disease. We can remember February last year, mid-February, we had an Italian entering our country. We can remember the man that entered the country in 2014 during the Ebola outbreak. Yeah. Yes. So it's require a coordinated international response. That means it is beyond only a country responding. So, and a public health threat and a public health emergency are almost the same thing. It's involving situations that may have negative consequences for everybody, and also includes events that have not yet led to consequences but have the potentials and require health response at whatever level, whether local level or national level or international level. This is just showing us how diseases spread from human, when we travel, population growth, through our healthcare systems, through conflicts. You can have diseases. That is the human factor. You have the animal factor, international trade, and interestingly, most of these diseases that we are having now, most of them are through the zoonotic diseases. Those are diseases that can be spread from animals to human, like our Lassa fever, some outbreaks, even Ebola. So we have been having to notice through food demand, because there's increase in agriculture technology using. We have some diseases that are coming back through because of antibiotic resistance, and some that can be through the environment, urbanization, deforestation, travel and tourism. So for our preparedness, that's the readiness and capacity of governments to respond, to anticipate, respond, and eventually recover from the effects of the health threat. So, and for us to be properly prepared, we need to plan, we need to allocate resources, we need to train, we need to do what we call simulation exercises to, okay, if this occur, what do we do? We need to do simulation and organize. But unfortunately, we are still very poor, especially in the Afro region. We are still very poor regarding preparedness. What we do is we respond. We don't prepare until it happens. It is when it happens that we start running. What do we do? But when you are talking, that's why I said I'm particularly interested in emergency preparedness and response, and because it's still very poor for us in my state. We have had that for like 10 years, having an EPR desk. But when you go to other states, most states of the Federation, even across the whole Africa as a continent, emergency preparedness is very, very poor. So we have history of emerging and re-emerging diseases. I hope we can see this, see all these things that we are facing now. Anthrax, bioterrorism, antivirus, human monkeypox. We had that in the country, just re-emerged in 2017 in some states. You can see S. aureus, that's an infection that is becoming resistant. We can see multi-drug resistant TB. We are still battling that. Nigeria has a very high burden of tuberculosis, and they are mostly multi-drug resistant. You can see Lassa fever in the country. You can see typhoid, diphtheria, and those are emerging and re-emerging diseases that we are fighting. So the red shows newly emerging diseases. Those are diseases that we have not even seen, like this SARS-CoV-2 virus, the COVID-19 is new. The blues showing us re-emerging. They are re-emerging, they are resurging. Then the black, deliberately emerging disease. This is a huge threat. Bioterrorism is a huge threat to us. And we have local examples in the country. We have meningitis, cholera, measles, yellow fever. Right now, apart from the COVID-19, we have cholera outbreak simultaneously going on in some states of the country. We have measles going on in some states. We have Lassa fever. States like Ondo State, Edo State, they are battling Lassa fever, they are battling COVID-19. So we have all this going on in the country. So I just want to talk about the recent outbreaks in Nigeria in recent history. 2014, we had the Ebola. We can all remember Thomas Sawyer that entered the country and it started running Esa and the lives that were lost to our non-preparedness were even more than what we lost through Ebola, because we are not prepared. There was misinformation, there was disinformation, a lot of stuff happened. 2016, I can remember this very clearly. We were celebrating that we were about to
Oh, you. Hello. Okay, let's hold on till she comes back. Because there's a little break in transmission. Oh, okay. All right. Let's hold on. I guess there's some issue wrong with our connectivity. We'll try and get her back as soon as we can, because I'm already enjoying the lecture and I don't want to miss this. So we'll hold on for her. In the meantime, let me just quickly inform us about the fact that there's a recent resurgence in issue of COVID-19 cases. Of course, most people believe that we've already won. Of course, we've won, but still want you to be more careful. All right, welcome back.
Okay, let me try to share my screen again.
All right.
I'm sorry.
It's okay. You, of course, we have to cope with. Maybe next time we'll go to Zoom.
I'm trying to. I pressed the icon, but it's like village people
Yeah,
trying.
of course. You don't want us to get this information, and we have to get the information you're about sharing.
Okay, okay, I've seen it.
All right.
Okay, so sorry for the break in transmission. So I was talking about the polio reemergence in 2016. We were at a conference, we were celebrating. We are out of polio, white polio virus transmission, and we got a call. There was two cases detected of WPV1 detected in a state in the northeast, and we all went back from that conference to the field. So, and that is how we started the journey, but thankfully, we ended the journey in 2019 and we got our certification. And we had CSM outbreak in the northern part of the country in 2017. 2018, we had an unprecedented Lassa fever outbreak in the country. And that outbreak was very interesting because it shifted pace geographically. Before that time, Edo State was the epicenter of any Lassa fever outbreak in the country. But we saw in 2018 shifting to Ondo State. And
Wow.
it was happening in some local government areas. In Edo State, it's very interesting. In the local governments that it was happening before, it shifted to other local governments. Likewise, in in Ondo State, it shifted, and we saw it was in Ose before that we were recording high levels of Lassa fever, and it shifted to our local governments. And it also came to Akure North, Akure South, and it didn't spread to most others. It was unprecedented, and I remember I was deployed by the NCDC to help an international, because we had to ask for international, the NCDC had to ask for international support, and I was in Ondo State for 2 months helping that NGO to respond to that outbreak in Ondo State as an epidemiologist there. So we also had the 2017 monkeypox outbreak. I led the response. In Ekiti State, assisting the state epidemiologist. Then I was the emergency preparedness and response officer for the state, and we had the outbreak in 3 LGAs in Ekiti West, Ado, Ikere, and some states other also recorded. I could vividly remember Bayelsa State and Lagos State. And in 20, now we have COVID-19. So these are the major outbreaks we had in Ekiti, in the country. I love Ekiti so much, that is to me. So we can see how public health threats can spread. Diseases are only a flight away. December, we heard about COVID-19. By February, we had it. That Italian came into the country, and all of us began to run scatter. The NCDC had to mobilize some of us to Lagos State, to Ogun State. I was mobilized to Lagos. I couldn't go, but I had to go to Ogun State. I came back maybe over the weekend, and by the Tuesday I was planning to go back to Lagos to join the response, and we had an American coming down with the virus in our own state, and that was
I,
how.
I, I remember we called the stuff the Italia job back then. We named it after a movie.
Yes. How everything started in the country. I had colleagues that did not leave Lagos, even though they didn't plan. It was a phone call they got, and they rushed down to Lagos. They didn't leave Lagos for 3-4 months. Even in the lockdown, they couldn't see their family, they couldn't see, they didn't see their children. It was funny. I remember going to pick somebody at the border, somebody coming, being deployed to the States. There was no vehicle, they shattered the vehicle, they couldn't enter the state. I had to go to pick her at the border, Ondo State border with Ikare, Ekiti State border, to pick her to come to Ado. So it was very funny. So there is a global drive to ensure that every country can prevent, detect, and respond through some systems that have been put in place. We have the IHR. Some countries have been mandated, they have that mandate, and they are part of the IHR, that is International Health Regulations, which mandates you to report diseases that you know, or infections or outbreaks that you know can cause can migrate across borders to other countries. You are mandated to report. And the packages include real-time surveillance. There are some diseases we have a surveillance system in place in the country, routine surveillance, and also we have event-based surveillance, that when you pick up some diseases, you have to report immediately. Don't wait through the routine, maybe weekly reporting or monthly reporting. We have a reporting system from the community level to the health facility level to the local government to the state to the national and to the regional, and also we share with partners. So there's surveillance, reporting, monitoring zoonotic diseases, developing capacity, that is workforce development. I'm a graduate of the Nigerian Field Epidemiology and Laboratory Training Program in the country, and that program has trained hundreds of field epidemiologists in the country. We have we have a body in the African region, AFINET. We have a global body, TEFINET. So that's part of the workforce development, and we are the foot soldiers, we are the disease detectives that go to the field when outbreaks occur, when pandemics occurs. Then we have the emergency operation centers. Before the advent of Ebola in the country, there was nothing like that. But through the NCDC now, virtually every state in the federation have an emergency operation center, like a command room, control room, where everything relating to the coordination of the outbreak response is carried out. Is at the national level at the NCDC. We also have it at the state level. So, and they have been coordinated in such a way that they can respond as a generic structure that can be adapted to fit any and to respond to any outbreak. Right now we have COVID-19. We're anticipating cholera. We can also respond to cholera. Some states are battling both cholera and COVID-19. Some states are battling both Lassa fever and COVID-19. So the EOCs have been able to do that. We also have the AMR, antimicrobial resistance monitoring, because most of these diseases are emerging because of AMR. And there's biosafety and biosecurity. I've talked about strengthening the health system. There's a need to build and have a national laboratory system. I remember at the beginning of the COVID-19 outbreak, we had four laboratories in the country, 4 molecular labs, level 2. But right now, I think virtually every state has a molecular lab. In Ekiti, we have 1. Immunization definitely is part of the response activity strategies. Now we have COVID-19 vaccination as part of the response to curb the virus, and also I knew Lassa fever virus vaccine is about the last stages of testing and all that. Then you have to link in public health with security. You have to know. So with that, we have what we also call global health security agenda. So public health threats can be due to multiple hazards. They can place stress on health systems' capacity to cope. During the 2014 Ebola, the countries like Sierra Leone and Liberia, their health system collapsed, and they had to draft in people, responders. I know I have colleagues that went, epidemiologists, that some of them spent 6 months, and some spent 1 year, some spent 18 months in those countries, helping them to respond. Then the requirement pass is multi-system, it's multi-level, and there's every need to, is very visible with high media and political interest. Of course, for the COVID-19, we have the presidential task force. And I could remember at the beginning of the outbreak, Governor Sanwo-Olu coming every day to engage with the media to allay people's fear. And it causes fear in the community with exaggerated reactions. I remember during the 2014 Ebola outbreak, people were bathing with salt. You see travelers, people, I know we lost somebody, she, at the end of the day, she was a TB patient, she collapsed and everybody ran away because it causes fear and it can drive, have broader impacts. I could remember during the lockdown, people begging for food, there was breakdown of law and order. So let's talk about the pandemic of the moment. That's the 2019 novel coronavirus. So in 2019, I think around December, they noticed some people having pneumonia cases in Wuhan, China. And before you could know it, the virus rapidly spread to several other countries because, like I said, that slide showing that the disease is just a flight away. I think like maybe this week or last week, there was a report of monkeypox, I think in the US or maybe UK.
Yes, I read about it.
There was a report, and that means that person must have come
Must have come to Nigeria.
Yeah, went to that country and exported it out. So on January 30, 2020, because of its pandemic nature, within a month, the WHO declared the virus was a novel coronavirus. Nobody had ever seen this strain of coronavirus before, this type of virus, and it was named a public health emergency of international concern. And they named it COVID-19 on 12th February 2020. And I think around that time we already have, it was very, around that time we had the Italian coming into the country. So currently across the world now, it has threatened the healthcare system, it has threatened the economic, there's a huge economic impact. It's like more than 5 years I've not been with my children for more than 3 months at a time. At least they will go and come back to school, but I had to live with them for like 4 months, going to the EOC and coming back late into the night to meet cranky teenagers, restless because they were not used to stay in the house during the lockdown. So there was a lot of increase in domestic violence, separations, and some people also increase in the number of children, pregnancies and stuff. So presently we have 202 million cases.
Yes, I remember that. We warned that another epidemic is coming in terms of babies. So,
So it was something that has been, we are at war. It was like a war situation, but we are not seeing, we are fighting invisible enemies, a tiny, tiny, tiny virus
yeah.
that we see and locked down the whole world. And it was scary. It was a scary situation for people that consider and what is happening. Just like that, we were, and now we are in the third wave. We had the second wave, January to March. It came down by July. We started the third wave, and the virus kept on mutating. Now we have the Delta variant. We don't know whether we'll have the Delta Pro Max. We don't know whether we have that. So presently we have
Okay,
about
so we are dealing with plus now. You're already saying Pro Max.
we don't know because the virus keeps on.
This is not technophone. No. I don't understand all this.
So we have 222 million cases in the world. That means that around the population of Nigeria has had that virtually the size of the population of Nigeria has had the infection. 181 million recoveries and 4 million deaths. That's about the population of some countries. 4 million deaths. I know we have some tiny, tiny countries with population as 4 million. Ekiti State, our population is not up to 4 million. So we can imagine those number of people that have died. And in Nigeria, the NCDC reports us at yesterday, we have 176,000 cases. 165 of them, 1,000 have been discharged, and we had 2,178 deaths. We have had health worker infections. We have had, so I got the infection on the 1st of February this year, and I was in isolation for 17 days. And apart from the physical symptoms that you see, at night I couldn't sleep out. What if I sleep into respiratory distress in the middle of the night? What if I can't breathe in the night? What if? So that what if will keep me awake. I will not be able to sleep, and it was not funny. And interestingly, I was still working. I am in charge of disseminating results, calling people. You know, when you have to wake up every day and the first thing you do is to see the number of cases that have come in, and you have to call people and tell them, good morning, you are positive with coronavirus, and you have to allay their fears, and you have to talk to them, and you have to tell them it's not a death sentence. If we could detect the case early, we can treat you. You know, the mental stress was just too much, and I was down. I was still doing my work, and I was down for 17 days before I recovered, and I resumed to work the day I recovered. So it is not a funny thing. Now we are having an increase in number of cases, and there is the need for us to take this thing very serious. There is the need to take for us, because what we are having now, the symptoms people are showing now is worse than what we have been having. We have seen a higher number of respiratory distress, especially among the elderly. So we need to, if we are not taking the precautions for ourselves, we are taking the precautions for people. We need to take the precautions because of other people. So why do we have to protect ourselves and others? Presently, there is no known cure or vaccine. Okay, we have the vaccine, but even with the new
variants.
third wave, yes, with the new variant we are seeing people that have gotten their 2 doses of vaccine coming down with the virus. But the only thing is that they have a milder form of the infection compared to people that have not taken any vaccine.
Yeah, I think Dr. Lushola mentioned that in the afternoon.
Even when you have taken the vaccine, you can still calm down. We have been taking measles vaccine for years, but we still have people coming down. We have to
Okay.
learn every 3 years, we have to do supplementary measles vaccination, apart from the routine measles vaccination that we do at our health centers. So no cure yet. It's transmitted through droplets. Well, now there are some studies are saying it is airborne. So that means we need to take extra precautions. And you can infect many people. I remember we had a case that infected 10 people. We have a single case infected 10 people because they didn't, there was no, the index for suspicion was poor, and the patient has been moved across 2 or 3 excuse me, 2 or 3 health facilities before they now suspected, okay, let's do COVID-19 test for her. So many people has been exposed, and she alone infected 10 people. And we also seen cases of people not even having any symptoms. We did a study. We collected like 5,000 samples from people that were not having any symptoms, and we had 130 of them becoming positive. And we have had cases of people recovering within 3 days, no symptoms. And we have seen a particular case, the person did not have any symptoms, and he was positive for more than 2 months. And you can imagine if he was not detected, he was not having any symptoms, if he
Yeah.
was not isolated. This
It would
is
be like like a source.
yes, the patient was a health worker, and was he was infected for more than 2 months. He was positive for more than. We kept on taking the samples. We kept on taking the samples. He kept on coming back positive. What was happening? And for more than 2 months, no single symptom. And you can imagine that person just moving around, not isolated, and just it would have been like typhoid Mary. I hope he was
Yeah.
the waitress that was
Yeah, that was serving food in the UK.
selling food, and outbreaks of typhoid cough continue happening until they detected that it was her. She was not showing symptoms, so that person
Yes.
would have been like that. So that is why for some, like a disease like Ebola will show symptoms before you can infect other people. But for COVID, you can be asymptomatic, going about you, and you are positive, you are harboring the virus, and you can be spreading the virus to other people. So we have that responsibility to think of others. So contacts of a case can also transmit the virus. When you have contact with, especially close contacts with somebody, you can transmit the virus, and you yourself can get down with the virus and can also transmit the virus to other people. So most of our hospitals lack capacity. So especially a COVID-19 patient needs specialized care. So we need to think of that, the health system, the health infrastructure. Do we have the infrastructure in place? Thank God for COVID-19. The number of ventilators in the country has increased. The number of isolation centers in the country has increased. The number of molecular laboratory have increased. We now use rapid diagnosis test kits that within 15-30 minutes you can get results. But this is still not enough. If we have something that it can still get out of hand if we do not take responsibility, if we don't practice the non-pharmaceutical measures. So, and COVID-19 severely affects people that have diseases like hypertension, diabetes, HIV, TB, and they are more likely. This is what we have consistently seen. We have consistently seen most people that died are people that are older, people that have comorbidities like HIV, like diabetes, like hypertension. They are the ones that have been dying. So because of them, we have a moral responsibility to protect them. So we can have the disease and infection and we are asymptomatic, but we can transmit to other people who have uh, low immunity, and they might come down and they come down with the severe disease. So how do we contain spread of pandemics or diseases? Through travel restrictions, quarantines, by suppressing silent transmission, then also non-pharmaceutical measures like personal responsibility, distancing, using face masks. For some other outbreaks, it might not be that. It might be that you have to watch what you eat. You have to your drinking water, for like cholera now, people the type of water they drink. So these are containment strategies, and the response to outbreak are always coordinated. For in Nigeria, for COVID-19, you have the Presidential Task Force at the point, you have the Federal Ministry of Health, you have the NCDC having this, and at the state level, these are the response pillars. We have the coordination, which coordinates every other thing. You have the surveillance that looks for cases, do contact tracing. You have people at the point of entry, checking the borders, manning the borders, airports, seaports. You have the laboratory, which is very key for confirmation of cases. You have people at the isolation centers managing the cases. You have risk communicators communicating to the public, engaging the public. You have logistics, and you have to move from point A to point B. You need money, you need vehicles. You have research. People, a lot of researches going on. Some states are carrying out seroprevalence surveys. We did community testing last year, testing people that were apparently healthy. Then you have infection prevention and control. This is for this response strategies for COVID-19. For cholera, you might have something like environmental health, environmental pillar. For something like Lassa fever, you might need safe disposal of bodies, because the Lassa fever corpse becomes more infectious when dead than when alive. So it depends
Wow.
on the outbreak. Yes, the Lassa fever corpse is more infectious at death than when it is, because the virus multiplies, in the corpse. So the
Yes, definitely.
response, yes, the response strategy would, the pillars will depend on the type of outbreak. So I think at this point, I'm taking enough time. So I would like to acknowledge the WHO, the NCDC, the US CDC, and these other guys. Thank you very much. Back to you, Tayo.
All right. Thanks so much, Mama. This has been very enlightening. In fact, I'm seeing some informations that I don't think I was even privy to before. So I've already asked I've noted on the page that people should ask their questions if they have questions. And I know that even after now, people will still, after we were through with the video, the live video, people will still have some questions under the post. So we'll be expecting those ones. So let me quickly ask my own questions so that we'll get some should I call it some answer from you before you leave us. Now, I'm very particular about the last information you shared about those. Should I call it the tiers of information? Those should I call it organogram? The last one. Those group that involve the risk communicator, case management. Do we really have those in all the states?
Yes.
Or you people are the one dividing yourself into, because I know you are in about more than you'll be in about if those groups are 10, you'll be in about 8 of it, or even in all of them. So how are you guys coping? Do we have people monitoring all these units?
Yes.
Wow.
Okay. We have people, every state, at least every state has that pillars, or those pillars. We call them pillars. The response, the IMS structure. That structure is called the incident management system structure. So it's the IMS. So it is adaptable. You can adapt it for cholera, you can adapt it for Lassa
Okay.
fever, comes, you can. But this is what we have. What I showed was what we have for COVID-19, and it's at the national level, it's at the state level, and each pillar has a lead. I am the acting state epidemiologist for Ekiti State. I am leading the surveillance and epidemiology pillar. Is when it is a response, like I said, a response is multi-sectoral. It's not something that the Ministry of Health will sit down and do. You need people from the academics. Like the research we did, it was in collaboration with our teaching hospitals in the state, the tertiary institutions in the state. So you have collaboration from the Ministry of Information, Ministry of Water Resources, from everywhere. We have people heading the IPC pillar. Each pillar has a pillar lead, and under that we have so many people. And today, I think today is day 506 of the response in my state. And every day since the March 18th last year, we have been writing situation reports. Every state writes situation reports and send to the national. It is what each state generates that the national will produce. NCDC will not come out and say they have 16 cases in Ekiti, they have 10 cases in Lagos. It is what Lagos has reported that they would also report. So they have those pillars being manned by people, and we have what we call emergency operation center meetings. Depending on
Okay.
the outbreak, sometimes at the beginning of the outbreak, we are having daily meetings every day. Then now some states are having daily meetings, some are having weekly, some are having virtual meetings. But so those structures are in place and they are active.
Okay, okay. All right. All right, let me put it this way again. There's one point you mentioned about case reporting. Case reporting, of course, since I've been following your work, I know that you have you've made a lot of efforts in the Ekiti State concerning reporting of cases. At least I know about that. But I remember that at the beginning of COVID-19 outbreak, a friend of mine in Abuja, yes, was having issues concerning reporting of cases. Every particular outbreak has their case definition,
Mhm.
and around when outbreaks becomes a little bit should I call it heightened to a larger extent, the public has issues about how to report cases because they don't even know what to report, or maybe they don't know the right channel to actually report. Of course, NCDC gave us some numbers during those periods. I saw those numbers, but if we are being honest with ourselves, most of those numbers are not actually responding. We're not responding. Yeah. So how do we do the local? How do people do a kind of local network of reports? If let's say, and we are not only talking about COVID-19 now, about other diseases as well.
Well,
So
yes,
how do we go about that?
I mentioned that we have a system in place in Nigeria called the IDSR, the
Okay, yes.
International Integrated Disease Surveillance and Response. We have community informants at the community
Okay,
level. At facility level, we have the surveillance focal persons. At the LGA level, we have the disease surveillance and notification officers. And the community informants have very simplified case definitions, and they report to the health facility in the catchment area. And the health
okay.
facility also to the local government officer. If you go to health facilities, you will notice them call, there's a number, DSNO. The number is
Yes,
always there.
yeah, yes, yes. I think I've seen that.
DSNO, and they will put a phone number. That means when they see any case that they need to notify, they will call the DSNO of that local government. And during the COVID-19, the lines were working. I was with a line, and I know people were calling in the middle of the night and day. It was not funny. So, and it's still working. NCDC has a toll-free line, which is still working. And the lines, we have a call center in the States, which if you listen to our jingles, they will roll out the numbers. If you call the numbers, they are active. They are actually, but during the outbreak, there were a lot of prank calls, and people, you keep on calling, it is busy, it is busy, it is busy. So, and it's not as if those people will just sit down. Some of them are fully involved, some of them are doing active case search, they are holding phone, they are holding the phone. So those lines, then you can report to the nearest health facility. Even in private hospitals, you will see the number, DSNO, you will see that number there. So,
Okay,
and the
all
system
right.
keeping
All right,
like this.
thank you. So, okay, I just have to know, are you, I don't know, we're about rounding up. We're even past the 45 minutes mark that I put on this, but you know that this kind of topic, we have to. So, let me quickly, I just want to point something out, though I think is to substantiate what you said the other time, but in a different way. Ebola and Lassa. from my own research and studies, they have asymptomatic patients as well. In fact, that's the funny thing. The day I realized that, I almost screamed at my, I didn't know. I was like, are you kidding me right now? So they have, and maybe, though I won't say this as a form of suggestion anyway, because I know you're already doing much of those work. But if we are going to be screening for asymptomatic patients for COVID, I think as a suggestion, you should include those other fellows as well, those other fellow viruses. If you're going to, if you get to a community, yes, if you get to a community where Lassa or Ebola is prevalent, you should do screening for even those not presenting with symptoms. Because in most definitions of viruses that I've read, they will tell you that Lassa and Ebola present with mild cases. Yeah,
Yes.
yeah. So that means that at that point in time, they are also capable of being active carriers of the virus. So just maybe when you people get to where you discuss our fates in Nigeria, you can include that one and tell us. So okay, then finally, let me just ask this question. You mentioned some diseases that are known with AMR, that's antibiotics resistance. So can you please mention some of them, because I'm interested in those bacteria. Those are specific bacteria infections, right? So what are the diseases that are known with to have issues with antibiotics resistance in Nigeria? Just maybe one or two, so that people will be able to know exactly what to watch out for. Hello, are you still there? All right, I think she's finding it difficult to connect. All right, yeah. So we just need those ones to watch out for, those ones that are giving us issues with resistance rather. So what are those bacteria infections? Because I know that AMR will be synonymous with bacteria infections.
Well, the one I can think of right now is multi-drug resistant TB. That is
Okay.
that is a big issue, is a big threat, especially in Nigeria. We have one of the highest burden, if not the highest burden of TB globally, and we also have,
Wow.
yeah, and we also have multi-drug resistance in the country. So, the initial, I remember the TB caused TB is uh, or directly observed treatment, DOT. You have to come to the health facility, collect your drugs, use it there before you leave. But now they give the patients, so we are seeing multi-drug resistant TB, and they are very much at risk now with this COVID-19 pandemic.
Oh yes, they are one of the vulnerable population.
They are one of the vulnerable populations. So imagine fighting TB and
And
it's not,
COVID. Hey,
yes, it's
wow.
not responding to treatment, and you are also fighting COVID-19. And there's always TB, HIV comorbidity.
Yes, 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 yes. So somebody
So,
is fighting those three at once.
so that is very, 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 is the what,
My mind is just telling me that's village people things.
and you can also look at malaria. We had to, there was resistance to chloroquine. We moved from chloroquine to ACTs, antimycin-based combination therapies. But now, even the ACTs, the Plasmodium parasite is developing some form of resistance. You see people, when you take a course of ACT before, you are fine. But
Yes.
now, you yes, but now you notice people taking one course, taking another course again. Sometimes you have to shift from tablets to injection before.
Injections.
Yes. So multi-drug AMR is a threat, and it has to do with the major risk factor is the antibiotics that we are giving to our livestock. The
Hmm.
antibiotics we are giving to livestock, which they are excreting into the soil, and we eat the food. So it's a big threat. It's a big issue, and now we want to start what we call AMR surveillance. That is mapping out, really having a coordinated surveillance for antimicrobial resistance in the country. It's not yet, but I know there is something going on towards that, especially from the veterinary aspects. From the veterinarian, you know what we are doing now is One Health. That is the human, animal, laboratory, environmental. Everybody is coming together to fight these public health threats. Thank you.
All right. Thank you so much, Ms. Alowooye. You've actually made this beauty of bringing those who are actively involved. By the day that we're going to get, we're going to have a kind of get together for people like you and others as well. Because if you had been here when we did the stuff for vaccine in the afternoon, it would have been a very robust discussion because we have a professional in vaccine and vaccination and vaccinology, the guys in the lab with you in the field. So we'd like to bring the two of you together to look into each other's face and tell us
Me too.
exactly what is.
I wanted to join, but eventually
Yeah,
I
no, no,
was
no. You, of course, of course. You're always in the meeting.
actually
I'm even surprised you're able to join us this evening, sir.
this is my fourth meeting for today. I started the first meeting 8:30, and I've been having meetings back to back, and this is the last session I will be
No, no.
having today.
I hope this will be the last because I'm suspecting they will call you again for another meeting before the night
In fact,
closes. So,
calls are trying to call me, put my phone on do not disturb.
okay. Wow, wow. Thanks so much for the time. We appreciate it. Please, this is not the only one-off talk that you're going to give. We're still inviting you for more. We still invite for more. We are trying to build a kind of interactive sections between the professionals and the public because we want the public to know what and what they are dealing with. We want this is just the start, so that next time that we call you, you won't say that these people have come again. Please, we'll be coming again. Yeah, we will always be coming again. So that thanks so much for your time.
Can
We
I say,
appreciate you.
can I say a
Well,
word?
oh yes, yes,
I
definitely.
I want to re-emphasize that we are potentially in the third wave. We need
Okay,
to
okay.
take responsibility by using our face masks, washing our hands, using sanitizers, protecting others and us, not only for ourselves, for the sake of people, immunocompromised
Compromised
people,
people, yes.
people living with comorbidities. We have a responsibility to please use our face masks, wash our hands, and practice social use. Please, if where you are going is not compulsory, please stay inside your house, because we just pray that the rate of cases we are seeing does not continue like this over a prolonged period. We might be looking at restrictions if it
Wow.
continues like that. If it continues, and so please let us protect ourselves and let us protect others for the sake of others, especially if we are living with children. We have seen COVID-19 4 months old. We have seen 1 year, we have seen 4 years, we have seen 8 years, we have seen 89 years old. So it's not something that affects a group of people, or it's not something that affects people that are promiscuous. Because when somebody has HIV, you can say the person is promiscuous just by breathing.
No, no, it's not. It's not even the people. I think the era of saying HIV people are promiscuous are over anyway. We have people
Yes.
like,
So just by talking, just by sneezing, just by coughing, you can infect others. So please let us take responsibility. When we are not in our rooms, when we are outside, let us use our face masks and other non-pharmaceutical measures. Thank you.
all right, thank you very much, Ma. So see you next time. So thank you for those who have been listening. We hope to continue some other time. We're having some other lectures next week. We'll be informing you of all our activities. So thanks so much for your time. Thanks so much for your time, Ma. We hope to see you next time. Huh? So let's free you for your other subsequent meetings.
Thank you.
All right.
Bye.